Our research team from the Mass General presented some important clinical data looking at patients with chronic heart failure who came to the office at the Mass General Heart Center in multiple visits, and we followed these patients for about 1,000 visits over a one-year period. And one of the things that we did was at each visit we recorded a number of clinical variables that the patients would provide to us, you know, what their history, their physical, and what we did was we perfected a way of identifying patients who, within the subsequent few months of follow-up, were destined to suffer consequences of their heart failure. In other words, identifying clinical tools for predicting adverse outcome. We then looked at specifically something called worsening heart failure, which is something that a lot of heart failure cardiologists talk about in clinical trials, but there's actually no conventional definition for how to define what worsening heart failure is. And we came up with strict criteria by which the diagnosis of worsening heart failure could be made, and then validated it prospectively in this cohort, showing that, in fact, one could, at the bedside, without any other means except for history and physical exam, predict the near-term prognosis for patients with heart failure and reduced ejection fraction. We then looked at the effects of a special form of heart failure treatment, which is using a biomarker measurement to help guide heart failure therapy. This concept of biomarker-guided heart failure treatment is something that we're currently exploring in greater detail in a large NIH prospective study, NIH-funded study called the GUIDED study. But in this pilot for GUIDED, called the PROTECT study, which was done at the Mass General Hospital, we showed, in fact, that biomarker-guided management, which is standard heart failure therapy, but with a parallel goal to reduce end-terminal proBNP values below 1,000 with standard heart failure therapies, actually not only improve quality of life for patients and improve their cardiac structure and function on echo, but it also reduced episodes of worsening heart failure substantially. So we now have a definition for worsening heart failure that can be used universally in clinical trials moving forwards. We also have shown that therapeutic strategies that are favorable for heart failure can reduce this very important endpoint. So it really lends both value for clinical trial design, but also for patient care alike. It's a strong term to say something's perfected, but the data showed that if a patient had worsening heart failure, they had a 56% event rate for subsequent cardiovascular death or heart failure hospitalization. If they did not, they had a 6% event rate. So that's about as close to perfection as one can get in terms of a basic, non-complex way of assessing risk. It essentially is predicated on symptoms, signs, and physical findings. So the patient has certain complaints that they may offer, physical exam may find certain things, and together with that combination, there's a whole list of possible variables, we can really sort out risk very, very accurately. These things are available at the bedside. A good history and physical exam could find each of the variables that we use to define what worsening heart failure is. And so really, while I agree that you know, the importance of good clinical acumen is always necessary, these are not difficult things to recognize at the bedside. And so it can be actually implemented very quickly, you know, by busy clinicians every single day. It doesn't require specialized testing. It's an evolution. I wouldn't say it's drastic. You know, we know very well that good history and physical examination should always be the foundation to whatever we do. But since I am a biomarker researcher, someone who focuses on things that are beyond history and physical, it's always important to circle back to the basics and then look at how the basics can be used to inform a path forwards for novel means of managing patients. And in this study, what we showed was that while basic history and physical allows us to identify risk very accurately, newer techniques for treating patients, such as biomarker-guided heart failure care, can actually reduce that risk quite dramatically. So it's sort of old and new. To apply it on a global level, there are two ways of thinking about things. There's the clinical and then there's the investigational approaches. So on the clinical level, given the very clear and dramatic event rates in patients that have symptoms and signs of worsening heart failure that we documented, it's reasonable to suggest that such patients may be triaged to a more intensive management strategy following the recognition of these worsening symptoms and signs. So they may be put into a biomarker-guided treatment strategy, such as we showed, that reduced the risk dramatically. They might be put into a home telemonitoring program. We've heard at the AHA meeting here that home telemonitoring once again failed in clinical trials, but part of the reason why these approaches fail is because they try a one-size-fits-all, and a substantial number of patients may not need to be telemonitored. These patients that we identified with worsening heart failure strategies clearly need to be monitored more closely, and so they may be more eligible for this approach. From an investigational perspective, as I noted, clinical trials have been using worsening heart failure both as an inclusion criteria. That was a key inclusion criteria for the Socrates trial, which was reported out here at the AHA. But worsening heart failure is also used as an endpoint in clinical trials. So thinking about the fact that the definition of worsening heart failure that we came up with very powerfully predicts adverse outcome, we can consider this a so-called level 2 surrogate outcome. And it can be used, therefore, both for inclusion and inclusion as well as endpoint in clinical studies of heart failure as well. It has the advantage of lacking one of the things that the Socrates trial required, which was the need for hospitalization before patients were enrolled into the trial. Our definition actually does not require hospitalization. Patients could be intensively managed as outpatients without the need for inpatient stay.